Thank you very much, Professor Jose and colleagues. I'm Joao Lima. I'm a cardiologist by training, but I work in the interface between cardiology and radiology at Hopkins. I have joint appointments. I am originally from Brazil, as Bruno mentioned, so I'm representing Brazil as well. I'm happy to, but since I've lived here in the United States for 30, this is going to be the 40th year. So I'll be talking more about the U.S. Experience. I don't have slides. I had thought that we are in the very middle of the epidemics here in Maryland specifically. As you know, the COVID epidemics in the U.S. began in the Seattle area, but it was New York that had the biggest impact and burden first of the disease, and now it is spreading westward. And we are at Hopkins at the very, I would say that we are a little bit past the peak, we hope, but with the reopening of some activities by our governor a week ago, we are seeing already a recrudescence, or in other words, hospitalizations that were going down have rebounded up, and to some degree, even though deaths, which you know, lag behind a couple of weeks, and we are still seeing a decrease in the number of deaths here in Maryland. Johns Hopkins in Maryland has 5 hospitals, and another one in Florida, which is a pediatric hospital. But the 5 hospitals in Maryland have acted much as a system. So we have seen the most severe patients in the central hospital and the younger, because we have the units for extracorporeal circulation, and this has been used, and actually now we are using it a little earlier than when we first started. So we have right now about 100 patients in the hospital, about 30 or so intubated under mechanical ventilation, and about 8 or so in extracorporeal in the extracorporeal unit, and this situation has been stable for the last I would say 3 to 4 weeks. That has been our situation in the Hopkins system. So today I was just to give an update on how things are in our area, because Maryland right now is one of the hot spots, so to speak. Chicago and Maryland are one of the places where the epidemics are still quite intense. About 10% of the tests performed here are positive, and we should be conceptualized as a metropolitan area that involves Baltimore, Washington, D.C., and the north of Virginia. And we are acting as such, and that's where the epicenter of the activities are. Now, leaving the acute epidemics for just a little bit, and talking a little more specifically about imaging, the modality that has been used the most is chest X-ray. We have been following the American Radiology College of Radiology recommendation to use CT only in the patients who are more severely involved. And MR has been used only on patients who have cerebral changes. That's where the concentration of MR cases have been. And since we have had the younger population for the whole system, we have seen this only on the patients that have had microembolization for the brains, encephalitis, and I'm really thankful for Professor Saba for the review that delineates quite well, and as Professor Doucet emphasized, the cerebral syndrome from a cardiac standpoint, which is my specific area. We have used echocardiograms that are performed in a portable situation, and we haven't seen as much left ventricular dysfunction, systolic dysfunction. We have seen more diastolic dysfunction. There is a syndrome very similar to myocarditis, to acute myocarditis. So if you look at the EKGs of these younger patients that are transferred to Hopkins, what you see is it is as if you're seeing epidemics of viral or Coxsackie myocarditis with very strange looking EKGs. And that appears to resolve as people recovers from the acute infection, but we don't really know. And we are looking at it as a myocarditic hit that we are very interested in the consequences. The pathologic studies that are available show that from China and also from Germany and from other places that have been involved in the epidemics shows myocarditic involvement more as edema than really a lot of cells, a lot of inflammatory cells, as you see in an acute myocarditis, say again by Coxsackie or by other. So it's an interesting, appears to be an interesting pathologic situation, but there's plenty of electrical disturbances. In other words, we realize that the myocardium is being hit. And if we follow the model of myocarditis, what we are afraid of would be a continuous immunologic reaction to that and the appearance of damage later of the myocardium.
Okay, and yeah, another point is you have the EKG, so you can have the proportion of people and also enzymes, cardiac enzymes, so you can know the proportion of people with these disturbances and maybe also compare to the results of MR. So does it make sense to scan only severe patients, or does it make sense to look at mild or moderate patients that maybe did not have much symptoms, but might have a scar and might have a pace troubles in the future? And so how do you position this screening of patients?
Yes, about less than 10% of the patients at Hopkins have had troponin elevations that are very worrisome. And those who went to the cath lab didn't really have, it was pretty clear that it was coming from the myocarditis. The ones who have had echocardiography, and I would say that, again, it falls around the 10% range. And those don't have a lot of systolic dysfunction, but they do have a lot of diastolic dysfunction. But a much greater percentage, and I can't give you the numbers exactly because we haven't done the EKG analysis in this much detail, have signs of myocardial involvement. So who would be the patients that would worry me? Would be those that had an EKG that looked very abnormal during their acute phase. And those abnormalities, again, are very different from one patient to another, just like an acute myocarditis. There are changes in ST segment elevation, depression. It looks like they're having an MI, or they have intraconduction abnormalities. All of that reflecting the fact that the myocardium is involved, but how much of that is going to translate in damage, we hope very little or not at all. But it's a lot of wishful thinking. We know that with this degree of damage, there will probably be consequences that that we are very interested.
I have another question, then I will ask Luca and Joseph to give to ask a question. But I have another question about the target of some people that might be followed because they have a profession where they are exposed to cardiac risk. And I'm taking one is obvious is the sports people.
Yes.
Those people, for an example, in France, we are very concerned about our teams, our national teams, our local teams that are playing every Sunday, but we don't know, should they go play again, or who should be tested if they are positive? For an example, you get positively tested on the serum, so you may not have a very severe disease, but maybe mild symptoms. What to do with those patients? Should we check their myocardium with an MR? Is that only ECG or enzymes? Enzymes may be too late. So what is your feeling about those population?
We are in the same, going through the same thoughts. And by the way, I really would like to hear from our other colleagues how cardiac involvement has played out in other places, because as I said, we have a perhaps a younger population than in other hospitals at Hopkins. There has been more involvement of the myocardium, of the heart, with more coronary artery disease involvement. Now, back to your question, Professor Jose. I would say that it's an exercise stress test that would tell us who are the patients who should have MR. If patients have arrhythmia during effort, those would be the patients I would be worried about. That's the kind of protocol we are thinking for people who are involved in contact sports that require a lot of cardiac activity. And then for those, MRI to see if delayed enhancement is present. And again, is the presence of delayed enhancement that really tells us if the likelihood of sudden death is much greater than, and we should advise the player to then not play contact sports. It's in myocarditis due to other causes. This has been very difficult to enforce in some cases, as you know, but we know that the presence of scar, delayed enhancement caused by myocarditis, is a very strong harbinger of sudden death in athletes that perform at a very high level. That's basically the protocol that we are planning to implement. But we are very interested in these MRI studies of people who survived, to have a sample of how much we should expect to see. And I don't know if in other institutions, MRI studies on patients who survive COVID are being performed. I would be very interested to learn what is surfacing. I know there isn't much published yet, but I know everybody is interested in that.